Zaczynamy? Tak. Ladies and gentlemen, we would like to introduce the special session of the American Heart of Poland, Innovation in Medicine. And the first speaker will be Paweł Kaźmierczak, member of the board of the American Heart of Poland. We can start, I think so.
Thank you so much. For me, it's a great pleasure and honor to have this opportunity to open this special session, because this session is a very special one, because combines experiences of service providers and engineers. So I would like to show you a short overview of how we are thinking about the future of cardiology in terms of collaboration and cooperation with engineers. So, first of all, why it is so important for us? This is important for us because cardiovascular diseases remains the leading cause of mortality globally. About 80 million of deaths each year are caused by cardiovascular diseases. So this represents about 32%, in Poland especially 40% of all deaths in 2023. So it is very important to cure, to identify, diagnose, and to cure cardiovascular disease properly. Also, which is very important thing, that CVDs are the leading cause of not only deaths, but also morbidity and disability worldwide. So this is very important to be very innovative and to use novel technologies to cure those kind of patients. When we look closer at the market of the technologies and innovations in cardiovascular, we can see that this market is very interesting. This market is very interesting because this market is huge and is growing very rapidly. So we know that the global cardiovascular devices market is valuated about $55 billion in 2023, and will achieve a number of nearly 80 millions billion of US dollars in 2030, which represent annually growth of about 6.3%, which is very impressive, especially when we are looking at, for example, TAVI market. TAVI market will grow with the rate of more than 14% each year. So what are the key drivers of this growth? The key drivers are aging populations. We know that the population over 60 years of age is expected to reach 2 billion of people by 2030, and significantly increase the demand for cardiovascular procedures and devices. The second stream is technological advancements, especially in terms of artificial intelligence, machine learning. And the third is increased demand for minimally invasive procedures. So when we look closer at what is happening in innovations in cardiology, we can identify 6 major streams. The first is wearable technologies and real-time monitoring. During past 10 years, we've made impressive progress in terms of using wearable technologies and real-time monitoring, especially in ECG signal monitoring, heart rate variability, oxygen saturation monitoring, continuous blood pressure monitoring. Each of us, I think, as I use these wearables to measure our key So let's go to the clinical application. Yes, of course, it can be used for the arrhythmia detection, especially for atrial fibrillation, early atrial fibrillation, and when it is combined with the telemedicine platforms, it can be used for early diagnosis and for early contact with patients with atrial fibrillation. Also for remote cardiac rehabilitation, we've made a big clinical trial in American Heart of Poland, including about more than 800 patients rehabilitated in their home environment, and for the heart failure monitoring, especially in the ICD placed in the cath labs. So what are the challenges for this part of the innovations in cardiovascular medicine? Of course, data accuracy, especially in terms of the quality of sensors used to capture data, user compliance and data security. We clearly know what's happened with Garmin application a few years ago with impressive data security issue. So the second stream and very important stream is, of course, artificial intelligence and machine learning, a topic which is very large and vast. So we have a multiple application for using artificial intelligence in medicine, especially in cardiac imaging, like the diagnostic imaging is the first and very important place to use artificial intelligence in medicine, but also predictive analytics and heart failure management, drug development, and personalized treatment. I saw a few days ago a very interesting software helping new doctors, fellows, and young doctors to make precise diagnostics, and it is very useful in terms of training and developing a new trained staff. So what are the benefits of use of artificial intelligence in medicine is, of course, improved accuracy and speed, early detection and prevention, and personalized care, of course. The third one is robotic technologies. A lot of questions about. We know now in Poland 2 systems of robotic surgery, not very common in cardiovascular, but we know that, for example, Siemens introduced robotic assisted PCI. It's called CorePath Gear X, which is fully automated system for stent placement in coronary heart disease. Also, robotic assisted heart surgery with Magellan system is available in the Western country. Also, electrophysiology and ablation procedures can be held by using stereotaxis knob. It is a magnetic field system which helps to precisely place the probe during ablation procedures. Fourth one is three-dimensional printing. Three-dimensional printing has a very narrowed application now in cardiovascular medicine. It's mainly used for training and educational purposes and for patient-specific anatomical models for preoperative planning. I think that we must wait some time to be sure that we can produce custom implants and prosthetics using three-dimensional printing. But it will lead us to the personalized and patient-specific care, which is very important. The fifth one is augmented reality, used generally in surgical planning and preoperative visualization and medical education and training of medical staff, and also for patient education, which is very important. And last but not least is the novel materials. We can talk a lot about new materials, but there is a lot of research is made every year in research of new materials in cardiovascular medicines. For example, it's a PLLA, which is a bioresorbable vascular scaffold. There was a product on the market introduced by Abbott, used as a coronary stent, but now we are trying to rethink bioresorbable stents, and now, for example, in American Heart of Poland, we also work on the introducing such materials in our practice. But also biodegradable polymers are in drug-eluting stent, tissue-engineered heart valves, for example. We are looking for the tissues which are resistant to calcification and have the antithrombotic coatings. So, finally, how can we reach all this, and how can we implement all this innovation in our day-to-day practice? Is of course by startups, and startups play a crucial role in driving innovation in cardiology. We can estimate that about, in cardiovascular space, it's about 10 to 12 billion US dollars in invest in by 2025 as venture capital firms, corporate investors, and private investors. So we know that the way is very difficult, because especially in cardiovascular, there is a long way, mainly caused by the regulatory hurdles. We know that the time to market is about 5 to 7 years for each startup. Only 20% of them will survive and will introduce their product on the market. And the mean cost of implementing a new product on the market is about 100 million of US dollars. So this is a very long and troubled way. So what is the future of startups in cardiovascular innovation, in my opinion? First of all, the demand for remote cardiac monitoring solution will be growing very, very fast. Then, of course, artificial intelligence, and at the end, we hope that some kind of bioprinting it is possible and can be one of the main target of startups acting during next years. What is the situation in Poland? Of course, I represent the position of the medical service provider. It is not a common opinion, but I think that we can be proud of Polish healthcare system, because Polish healthcare system provides us with a solid foundation for treating all cardiovascular diseases. But in terms of integration, all cutting-edge innovation and artificial intelligence, we have a lot to do. So why this situation is so complicated with a very developed, good healthcare system and no innovations implemented day by day? It's first of all lack of differentiated tariffs, in my opinion, because we has not fully implemented differentiated tariffs for the reimbursement of innovative cardiovascular treatments. So this means that hospitals receive the same reimbursement for using older technologies as they do for adopting new, more advanced solution, example, artificial intelligence, minimally invasive procedure, etc., etc. This situation, of course, reduces the incentive for healthcare providers to invest in cutting-edge treatments, and we tend to use the old one. Also limited coverage for remote monitoring and artificial intelligence. We have some regulation in Poland, but we still wait for tenders, so this is not a common medical service. And the third one is a budget constraints, as we know that we spent about 7% of our GDP, and we have still some gap between us and the Western countries, especially Germany and France. So what are the opportunities to improve access to cardiovascular innovation? Of course, updating reimbursement policies, first of all. The second, maybe government incentive for healthcare providers, maybe some kind of grants for purchasing new equipment or training of healthcare professionals to use new devices, for example, robotic surgery. Of course, we also expect expanding public coverage for remote monitoring, which is ready to implement, but we still need for the last step to do it. And increasing investment in cardiovascular startups. For example, we have a very notable startup in Poland based in Kraków called Cardiomatics, which uses artificial intelligence to analyze ECG data, and we are very happy to collaborate with them for a few years already. So thank you for your attention. Let's stay in touch. Yes, please write me an email if you have some questions or just need a contact with me. Thank you very much.
Thank you very much. And the next speaker will be Professor Przemysław Nowakowski, our vascular surgery. He's working in the Chrzanów.
Do tego. Thank you for the invitation. My topic is connected to real life, not so with the future, but solution our problems are in future. Personal experience with using biological materials in vascular reconstruction, especially in infected field. Few information about infection in vascular surgery. It is very huge, devastating problem with which can lead to anastomosis, rupture, pseudoaneurysm, hematoma, sometimes massive bleeding during graft disruption, and sometimes sepsis and death of the patients. What can we do? Small local infection treatment, partial graft replacement, drainage, antibiotics therapy. If graft removing is necessary, what next? Reconstruction or not? Another synthetic graft, using graft with antibiotic or bacteriostatic drugs, and sometimes removal without reconstruction. This is possible, but yes, with high possibility of huge amputation. And sometimes we can do extra anatomic vascular reconstructions. Generally, graft infection in vascular surgery outcomes in the past and current time are not satisfactory. What in the future, using biological materials, frozen or fresh allogenic material grafts from cadavers, deep vein usage, it is possible, but sometimes not easy in massive infection, and biological materials from bovine pericardium. This is one on the market, one on the world, prosthesis biointegral, but unfortunately from 2 years now out of stock. And short history next, biological materials, small intestinal submucosa, few information and papers from PubMed, and using this material in vascular reconstruction. What is it? This is extracellular matrix from pig small bowel, material without animal cells, allowed for cardiosurgery, not for vascular surgery. but only as a patch. This is not prosthesis, this is not tube, this is only the patch. And our question is, can we make a prosthesis from a proxy-core patch? Few words about our hero proxy-core material. This is more resistant for infections than synthetic material, modulates biologic healing and reduces inflammation and supports the angiogenic process. And let me to show only 4 cases with using this material as a graft. Case 1, young 58 years old man with infection, with acute admission, with ruptured pseudoaneurysm in the groin. First line treatment, pseudoaneurysm excision reconstruction with a partial changing prosthesis with argentum and triclosan. But after 4 weeks, no treatment, no groin wound healing, and graft infection in CT scan. Next treatment, total removal, infected iliofemoral graft, reconstruction, yes, because if we perform not reconstruction, we have a huge femoral amputation, lack of biological prosthesis, lack of biointegral graft. But on shelf we have on hospital proxy-core patch. And treatment, total removal of the infected graft. There are the picture from our treatment from operation. And from 2 parts of proxy-core patch we perform, we have formation straight tube, as you see. And finally we have 1 long tube prosthesis from proxy-core patch. And new graft implantation from proxy-core, wound healing, zero problems, patient in good condition, walking was discharged 2 weeks after operation, but unfortunately after 1 month follow-up, we have information from the family, sudden death at home. Next case, patient, very complicated patient, 66 years old man. After treatment, retroperitoneal abscess in iliopsoas muscle on left side in general surgery department, and after about 10 months after this surgery, patient was referred from emergency unit with diagnosis of aortic wall disrupture with retroperitoneal hematoma. And a picture from CT scan with rupturing aorta and big hematoma on left side. We perform laparotomy. We observed aortic wall rupture about 5 centimeters above bifurcation, and probably from a penetrating aortic ulcer, aorta surrounded by inflammation and porlet content with infected hematoma and left iliopsoas muscle. We decided to implantation biological prosthesis from proxy-core patch. We perform creating a straight tube from proxy-core patch, and there are the picture with operation and our final treatment, implantation new prosthesis into our abdominal aorta. And after 1 and 2 months, angio-CT scans, proper flow throughout prosthesis, without leakage, hematoma resorption, but patient has still periodic suprafebrile state. 3 months after surgery, diagnostic hospitalization in general surgery from a reason bleeding from gastrointestinal tract in gastroduodenoscopy, small erosion in duodenum and suspicion prosthetic intestinal fistula. And in CT scan, we see bubbles near the prosthesis and in the hematoma. Another admission to vascular surgery, laparotomy, prosthetic small bowel fistula with symptoms was observed with wall damage and bleeding. And treatment, small bowel fistula closure, prosthetic removal, the closure aorta and iliac arteries, and extra anatomical subclaviobifemoral bypass with, unfortunately, synthetic PTFA graft. And after 2 months, patient was discharged from hospital. Next case, patient with critical limb ischemia cachexia after subclaviofemoral graft, after femoral amputation, and after few months after this surgery, acute admission to vascular surgery, graft infection in angio-CT scan with bleeding in the groin. Surgery, prosthesis removal, and subclavian artery reconstruction with the GSV patch. But 4 weeks, another acute admission, bleeding from the subclavian artery. Next surgery, subclavian artery wall damage, purulent content, and we perform reconstruction, new reconstruction with prosthesis from Proxicor patch with Strytrup, and after 6 days, patient was discharged from the hospital. And there are pictures from operation. And last case, patient after abdominal aortic excision with aortobifemoral graft, and 7 years after operation, pseudoaneurysm in left groin in angio-CT scan, symptom of infection, local liquid around prosthesis, but patient without fever, without sepsis. And our treatment, partial removal of left branch aortobifemoral prosthesis and new reconstruction with prosthesis formed from Proxicor. And there are the picture from operation, from reconstruction, but outcomes. This is very, very interesting. No problem without wound healing. Patient in good condition was discharged 6 days after operation. After 3 months in CT scan, without symptom infection, without pseudoaneurysm. But 8 months after operation, in control CT, suspicion of pseudoaneurysm next time on the left groin. And surgery, pseudoaneurysm excision, and reconstruction with next synthetic silver graft. And CT scan from the patient. This is a picture from last operation, and cartoon, my cartoon about schema. And what is on this picture? This is very important information. On with green marker, green arrow, we see a good-looking wall Proxicor prosthesis with good positive biological remodeling. But if we look at anastomotic place between prosthesis and biological materials, we don't see this. This is poor place of our treatment, and anastomotic place between Proxicor patch and synthetic material is poor point our treatment. And this final solution with new prosthesis. And short summary, graft infection are still Achilles heel of vascular surgery, unfortunately. Availability of biological prosthesis is poor. This is a future, maybe for in this place, this is good time for speaking about this. Proxicor patches as a biological material on shelf can be considered for prosthesis formation, especially in emergency cases. Connection biological graft with synthetic prosthesis is probably not resistant in long-term observation, poor biological remodeling, and long-term follow-up is not clear. But from my information, probably in the future we can use fabric-made tube grafts from Proxicor. Thank you. Last picture. As you see, coexisting tree and steel is possible. Maybe this is a green light for vascular surgery treatment in infection. Thank you.
Thank you very much. And the next one will be Krzysztof Sanetra, our cardiosurgeon from Bielsko-Biała.
Thank you for the invitation. It is a great pleasure to present to you this topic, especially that the development in this field is very spectacular in recent years. So I would like to discuss minimally invasive interventions for aortic valve disease. And just as a short introduction, aortic valve is a very important structure which is placed between left ventricle and aorta. So it allows all the blood, systemic blood flow that goes through our organism, and therefore any malfunction of the structure may present very great risk for our health and also life. Normally, aortic valve is tricuspid. However, there can be some anatomical alterations like bicuspid valve or even unicuspid valve. Both of them make the make the valve more prone to the disease. Yeah, and the primary problem is aortic stenosis when the effective orifice of the valve becomes more narrowed, which does not, thank you, which prevents the blood to effectively flow through the valve, and therefore it makes the our heart more diseased. It makes the heart failure to develop and may result in life-threatening condition. So these are some pictures of stenotic valve. In most of them, the three leaflets are unrecognizable. And there is a live picture on the right side. So as you may see, the effective orifice of this valve is very narrow. And therefore, there is a lot of pressure gradient between the valve and the aorta. Yeah? So how deep is the problem of aortic stenosis? It is the most common acquired valvular disease, and it is present in about 5% of population at the age of 65, with increasing prevalence with advancing age. So yeah, it's quite common. And the meta-analysis of studies conducted in Europe, USA, and Taiwan found that the population prevalence of aortic stenosis is over 12%, and severe aortic stenosis that should be an indication for interventional treatment is present in 3.4% of patients aged 75 years of older. So we have growing population that requires such treatment. The aortic valve also may be incompetent, which presents with regurgitation. This also leads to heart failure. However, it is much less common and usually associated with other heart diseases like enlargement of the aorta. In most cases, when I refer to aortic valve disease, I mean obviously stenosis, which is most common, and it's the huge epidemiological problem due to the growing age of our population. So the primary treatment for aortic valve stenosis is a classic surgical approach. So to do this, we need to perform a median sternotomy to visualize the heart. Then we need to cannulate the vessels, aorta and veins. Enter extracorporeal circulation, which is basically so-called heart-lung machine. We arrest the heart. Then we need to make the incision of the aorta. We remove all the calcium and the disease leaflets so that all the annulus of the aortic valve is clear. And then we place a prosthesis, which is basically placing sutures through the aortic annulus and the prosthesis cuff to tie them and implant the valve in place. After that, we need to close the patient up, decannulate, of course, previously, wean from extracorporeal circulations, so it is a very invasive procedure, yeah? And this is how it looks like. When it comes to prosthesis, we basically have two options, and the most important facts about them are summarized just below the pictures. We have mechanical valves which require lifelong anticoagulation and regular blood lab testing for the INR index. I will tell something about it a little bit later. However, those prostheses do not degenerate. On the other hand, we have the bioprostheses which do not require lifelong anticoagulation. However, they undergo the degeneration process. So this classic surgical treatment faces lots of challenges because we have perioperative risk increasing with patient age. We have a problem with sternotomy and wound healing. We need to establish extracorporeal circulation. We need to arrest the heart because it's the ischemia and further increases the risk for the patient. There is a problem of durability of bioprosthetic valves. There is an issue of patient prosthesis mismatch because we need to implant the prosthesis that has an orifice that would be sufficient for the patient. If we implant the prosthesis that has the effective orifice area lower than expected, then we leave the disease, yeah, because it's still there is a still gradient between the ventricle and the aorta. And there is an issue of anticoagulation for mechanical valves. So starting from the last, almost all mechanical valves have two discs, leaflets made of pyrolytic carbon, cuff made of dacron, and the orifice ring is made of machined graphite coated with pyrolytic carbon. And as I said before, those valves require anticoagulation. The INR, index normalized ratio, means basically how longer does our blood need to clot to be safe for this valve. And for most of the valves, the required INR is 2,5 to 3,5, so that means that patient is much more prone to bleeding. There is current update for valve aortic position that may become 1,5 to 2,5 sufficient, so that's a little bit safer, but it still makes the patient, especially older patient, prone to bleeding complications. There have been some solutions to this to engineer a valve that would require lower INR values. And the lowest on the market is the ONI-X valve, which has some differences in preparation of pyrolytic carbon. I'm not really aware of the process. I believe it's a kind of secret also. However, that makes the FDA approval for this valve for INR 1,5 to 2. So it's the one of the lowest in the market. Yeah. And on the other hand, we have the bioprostheses. And those present with two major issues. On the left side, you can see the stented bioprosthesis, and as you may notice, the orifice area is quite, the place where the leaflet are placed, yeah, it's quite narrow when compared to all the valve dimension. So that requires to put really big valve just to be sure that the gradients are sufficient for the entire patient. So there was a solution, and stentless prostheses were introduced into the market, like the one on the right side. And there is no cuff, as you may see. However, the procedure is much more complicated and longer than in the stented prostheses. Yeah? And the other problem is the degeneration of leaflets, because it may proceed really rapidly in some groups of patients. And, we have a recurrence of the disease then. Yeah? So that's the main problem that the biological valves try to address. There are many technologies, and this one is the one presented with a trifecta pericardial valve, when there was a technology of extracting lipids, reducing free aldehydes, minimizing cholesterol uptake, and stabilizing leaflet collagen, just to prevent the degeneration and calcification of the leaflets. There is a huge problem because sometimes the results from the clinical and preclinical studies are not, they do not fit the clinical experience. For example, for this valve, it was withdrawn from the market because of too early degeneration. And this is the newest solution presented by Edwards, Resilia tissue technology, which builds on Thermafix process and is treated with novel preservation technology to resist calcification more effectively and allows for the dry storage of the valve. So this allowed this valve to obtain 72% less calcium content after 8 months, which is pretty much spectacular. and we all have very high expectations of the durability of those valves. Recent studies are very satisfactory, but the clinical experience is presented clinical experience is about 7 years, so we still need to wait for the final results. Yes, so we have the problem of INR, problem of valve durability, and finally we would like to make the procedure less invasive. So some other approaches than conventional sternotomy were introduced. This means right anterior mini thoracotomy and hemisternotomy. The incision, as you may see, and the wound are much smaller. However, this makes the procedure more demanding. We still need to establish extracorporeal circulation and arrest the heart, and the extracorporeal circulation is established through femoral vessels. You may notice it on the venous and arterial cannula on the right side. And on the left side, you see a very small incision, so the surgeon's visibility and maneuvering is very limited. So there were some solutions from the industry to facilitate this minimally invasive access, for example, operative devices and new valves that would be more feasible for this approach. As an example of device, we have a RAM device, which basically allows us to place the sutures just like the surgeon does, just by pulling the leather, and it has a maneuverable jaw which allows to place the sutures on the aortic annulus quite precisely and through really small incision. And we have rapid deployment valves, which are very similar in terms of tissue to the classic surgery valves, but there is some different some alterations regarding deployment, because in this case, they have the flexible alloy wire form, and they have a stainless steel frame that goes beneath the aortic annulus. So you can see it on the left side. Actually, only the valve structure that is superior to the cuff is positioned above the aortic annulus, and this frame with sealing cloth goes below the aortic annulus, and it is expanded by a balloon. You just need 3 sutures to position the valve. Then it is placed down to the annulus, and the cuff and all the structures that are below the aortic annulus are expanded on a balloon, which also makes the implantation process much easier. And therefore, it is this valve is prepared when thinking of minimally invasive surgery. Yeah? And the results are quite good, because freedom from valve-related death at 5 years was 98%, and the valve orifice area was 1.6 square centimeters, and mean gradient about 10 at the 5-year observation. So it is really good, and it allows us to think very positively about this valve and generally about the minimally invasive approach. So we found solution to obtain longer valve durability. We found solution to perform minimal invasiveness. Still, we need to make extracorporeal circulation and arrest the heart. However, this procedure at this point looked very, very much more patient and surgeon-friendly, less invasive. Yeah. And when we thought that not many things more could be achieved, then there was this guy, Alan Krieber, who unfortunately passed away recently. And he introduced the concept of transcatheter aortic valve implantation. The first procedure was performed in 2002. And as you may see, the principle for this transcatheter aortic valve implantation, sometimes called transcatheter aortic valve replacement, these are synonyms actually, is that the valve is crimped on a very narrow catheter. which is introduced through femoral vessels, subclavian vessels, jugular vessels. There are also, if someone wants to perform surgery, maybe introduced transapically. However, through really small 3 centimeter incisions without need of arresting the heart. The crimped valve is positioned in aortic position and then expanded under fluoroscopy. So that makes the procedure much less invasive when compared to all the other surgical approaches. There is no need for extracorporeal circulation. In most cases, it's like you don't need to even perform anesthesia on the patient, so the patients are awake. They can speak to you during this procedure. And it's still a heart valve surgery, so the technological advancement in this field has been very spectacular. And basically, transcatheter aortic valves could be divided into 2 groups. We have balloon expandable valves with a flagship of Edward Life Science Sapien. And we have self-expandable valves where the valve has a radial force, and while being released from the catheter, it expands rapidly and finds its position in the aorta. And example for this can be Medtronic Evolut, also very popular valve. So there are some differences in design of those valves because the balloon expandable valves, like for example Sapien, have usually cobalt chromium frame with bovine pericardial leaflets, and they have a sealing skirt technology to perform paravalvular leak. Whereas the self-expandable valves have the nitinol frame, and therefore they expand and position themselves into the aorta. They also have the leaflets made of pericardium and also usually a cuff to prevent the paravalvular leak. Delivery systems are really very flexible, and they allow nowadays to introduce the valve for a vessel as small as 5 millimeters. So for the larger valves, because they all need to be measured before the procedure, is 5.5 millimeters. So we can successfully perform this procedure through femoral vessels and subclavian artery, or for example carotid artery. So there are lots of options for the patients. Yeah, and this valve also has a unique feature of performing so-called valve-on-valve procedures. And this is a fluoroscopy of a patient that had a valve replacement with a biological valve. You can see the sternal wires and the contour of the valve on the left side. And then the transcatheter valve is positioned into the old degenerated bioprosthesis and then expanded. So it allows us to perform reoperation without opening the patient chest. So it's also very interesting option, especially for the patients that have very high risk of reoperation. There is also a procedure for isolated aortic valve regurgitation. However, it is rather challenging because absence of annular leaflet calcification, which is necessary for device anchoring and stabilization, because of increased stroke volume secondary to severe aortic regurgitation, and because possible presence of aortic root dilatation. The market also has introduced some devices that are dedicated for aortic valve regurgitation. For example, Trilogy valve, which has sealing ring that provides sufficient anchoring and annular conformability, and a delivery system that allows to deploy during single action through a simple advancement mechanism. So it's also possible to treat isolated aortic regurgitation through this method. Everything seems perfect. However, there are still some concerns regarding the transcatheter aortic valve replacement when compared to classic surgery. And that stands mainly for paravalvular leak, which increases risk of mortality, cardiovascular death, and rehospitalization. Atrioventricular block requiring permanent pacemaker implantation, so it's another procedure and also increases the costs for the patient, for the provider. However, this also increased the risk of one-year mortality and is associated with lesser improvement of ventricular contractility. There is an issue of access to coronary arteries to perform percutaneous coronary interventions due to the placement of the delivery system. There are also some vascular complications possible, and of course there is an issue of costs and cost effectiveness. To address those issues, I have brought the results from the partner-free trial, which compared the transcatheter aortic valve, SAPIEN-free, and traditional surgery. This is a sub-analysis of low-risk patient cohort. And as you may see, the death, stroke, and rate of hospitalizations favor the transcatheter aortic valve replacement. Similarly, as the hospitalization to heart failure, life-threatening major bleeding, disabling stroke, or atrial fibrillation. However, the risk of moderate and severe paravalvular leak, it is particularly absent in the classical cardiac surgery, because all the ring is prepared and it is or sutured all around. So there is during the successful surgery there should be no paravalvular leak. However, it is present in transcatheter aortic valve implantation. And for this valve, it was estimated at about 1%. However, for the self-expandable valves, it may be much higher, about 3.4% regarding to different studies. And the pacemaker implantation. There is a conduction system going just below the commissure of right anterior of right leaflet and non-coronary leaflet of this valve. So it's very easy to damage this conduction system, which results in atrioventricular blood and necessity to provide the pacemaker for the patient. Classical surgery also is associated with risk of pacemaker implantation. However, it is much more expected in transcatheter aortic valve replacement. So this is basically the same that I said. And yeah, paravalvular leak. So this is something that, as I mentioned, increases mortality and risk of rehospitalization. The risk factors are shape and size of the annulus, presence of bicuspid valve, left ventricular outflow tract and ascending aorta angle, distribution of calcifications, other anatomical features like valve area, ejection fraction, high transvalvular gradient, procedural risk, and finally the valve design. And to prevent the paravalvular leak, the valves have been designed with the cuffs that should make the complete sealing all around the valve. The new generations of both transcatheter, of both balloon expandable and self-expandable valves are very similar solutions. However, as I said before, there is a little bit higher risk of paravalvular leak in self-expandable valves. Atrioventricular block requiring pacemaker implantation also has the risk factors of septal wall thickness, non-coronary cusp thickness, pre-existing conduction disturbances, procedural risks like low implantation or post-implant prosthesis expansion, and finally valve design, because it is also more present more often in self-expandable valves, which may be up to almost 9%, which is quite a lot, and there is a huge field to improve that. Access to coronary arteries, both balloon expandable valves and self-expandable valves have excellent design to effectively access the coronary arteries. In balloon expandable valves, there is, regarding to the studies, it is about 100% success, and in the self-expandable valves is almost 97.5% success. So regarding this point, all the design of the valves is very satisfactory and allows to perform further many invasive interventions to the patient, like stenting, if they are only required in the future. So. Yeah, and the vascular complications, they are usually associated with the introduction of the valve through the system. The incidence is about 4%, so it's also quite a lot. We would like for this incidence to be much lower. And those vascular complications may also be very spectacular. They may be associated with aortic dissectional rupture. There can be also access site or access-related vascular injury. Distal embolization, when we move a plaque that just from the lower extremities or the aorta. There may be a use of unplanned endovascular surgical interventions, of course, associated also with the introduction of this device. There can be an ischemia of lower extremity, also associated to plaque rupture or even intraprocedural when there is no adequate blood flow to lower extremities. And also very rare, but surgery for access site-related nerve injury may also occur. And finally, we have hospital costs, because the differences here are very spectacular. So the stented bioprosthesis, which I have discussed in the beginning of this presentation, mean hospital costs, which is calculated from 45 clinical studies with 12,000 patients, are $30,000. For those rapid deployment valves that are indicated mainly for the minimally invasive surgical success, the mean costs are between $37,000 and $44,000. And for the transcatheter aortic valve replacement, the hospital costs are about $70,000. So it is 5 times more than the original surgery. So that is also a challenge, not only to make the devices more effective, but also more available by reducing the costs. Thank you for your attention. If you have any questions, I am all yours, so just be free to ask them.
Thank you very much. Now we want to introduce our friend, Professor Wojtek Wojakowski from the Katowice.
Thank you so much for staying late. I hope you are not very tired with the valvular heart disease. I'll just cover brief topics that are not overlapping with the previous talk. So why is it important? It's important because roughly 30% of patients who should receive the treatment in Europe and its current data are not treated. And valvular heart disease treatment is very dependent on technology and is costly. However, the disease itself, it's something that shortens life. For 60 years, we know that if somebody has aortic stenosis with symptoms, he will die. So currently, the waiting lists in Poland for aortic valve replacement, especially by TAVI, it's several months. And we know that if patients are on the waiting list for more than 4 to 6 weeks, they die in excess. So this is unmet need, and very current data show that the number of patients needing the valve replacement therapy increases. And also there is an unmet need because we start to treat patients who are older and they were rejected from surgery years before. So what I would like to show is that we very much need engineering, because now the problem of doing intervention, it's a less burning one, because we can do the intervention safely and we can do many interventions per day. But the whole organization of the treatment and planning of the treatment is very dependent on the technology. So first is a screening, because in large cities where there is a good access to the healthcare, the echo is something that can be done very easily. And there are new technologies like this on the right side, which can help to screen for valvular heart disease in places which are not very well served by the healthcare. On the left side, it's one of the first echo machines. So even more interesting, and this is done by IT people more than physician, is that AI-driven algorithm can diagnose aortic stenosis based on simple 12-lead surface EKG. And in EKG, we may see some features of heart overload and hypertrophy, which are related to the valve disease. And as you see, this is just one of the examples that using more than 77,000 EKGs, the algorithms learned to diagnose the valvular heart disease, and the effectiveness of this approach is quite reasonable. So probably in the future we will have more patients screened, and we will have some screening process, for example, EKG, simple blood test, and simple handheld echo, which can differentiate patients who need to be treated soon. Also, we need to have more and faster multi-slice CT, because all the TAVI procedures, all the mitral procedures done by transcatheter ways are dependent on good quality multi-slice CT. And when we look through the groups of patients, there's an indication creep, especially in the United States, and the younger patients are treated using percutaneous valves. All the patients who are not clearly inoperable or clearly operable should be discussed within so-called heart teams, so cardiac surgeon, cardiologist, non-invasive cardiologist, imaging specialists, and sometimes more specialties are invited. And this was quite an easy task if we treated 2 patients per week, but now we treat 10 patients per week, and we have waiting lists of 150 patients for TAVI, and this cannot be really done by few people who need to operate at the same time. And this is one of the examples that AI algorithms can help to pre-process the data from imaging like ultrasound, CT scan, coronary angiogram, and come out with best solutions for treatment. So the heart team will need only to discuss the most difficult patients and discuss in case there is a doubt. Also, we know that not only patients with severe symptomatic aortic stenosis should be treated, but sometimes we should treat earlier, because even if the patient is asymptomatic, there is a damage of the myocardium, there is some overload, and this process is continuous. So now there is a trend to treat some patients in early stages of the disease to improve their outcomes. And for this, we need very good algorithms. We need to decide whether we use biomarkers. Sometimes by single blood test, we can have 50 biomarkers. We need to discuss the echocardiography versus cardiac CT, which all of these modalities can have distinct information that will allow us. For example, extracellular volume and cardiac fibrosis in MRI can direct us to treat the patient earlier, because there is already some damage done to myocardium, despite the fact that the patient is not symptomatic. In the same manner, the strain measured by echo, it can be measured by MRI, also can direct us to early treatment of some patients. Current generations, beautifully described by my colleague, they have some limitations on the right. I will not repeat all of them. So there are new technologies, and this is clearly an engineering field, because the fact that the one valve is superior to another is not only the surgical technique, it's also the biomaterials. There are some valves that try to address the problem of structural valve deterioration by using the polymeric leaflets, using different design, using robotic leaflet preparation, and so on. So in near future, we will be facing a dilemma, which device to choose for which patient. And there are numerous combinations of anatomy, clinical situation, and the valve design. So this will be probably helped by some sort of facilitated procedural planning algorithm based on cardiac CT, on clinical data, and again, one of the first algorithms for TAVI planning, especially if we need to decide whether to take the high stent valve like Medtronic or to use the short stent valve. Each of those valves have its own unique features, but this will help us to plan and choose the valve for each patient. This on the top left, it's very old movie from our cath lab when we played with virtual reality, and this is the CT scan of the actual patient, which was overlapped on the patient, on the same patient. So in the middle, you see we planned to use this visualization of the femoral arteries to plan the puncture site, so we don't have to use contrast again. So this probably in the future will be something that may be useful for some procedures, especially if you want to combine fluoro and X-ray, fluoro and echo, or fluoro and CT scan. So this I will skip, and there is also a lot of peripherals, auxiliary techniques which need to be used in some extreme cases, like the ultrasound emitting balloon that will relieve the calcium deposit in the femoral arteries. Sometimes, as you see in the middle bottom of this slide, there are critically stenosed iliac vessel, and sometimes the amount of calcification is so huge that it cannot be done by balloon itself. And this shockwave, the balloon that emits the shockwave in a similar manner, the one that's used for kidney stones, can deliver an energy that is equivalent to 50 atmospheres, and it cracks the calcium, and it allows us to proceed with the procedure. Some devices facilitating the leaflet modification to improve the coronary access, or in the bottom left, very simple but useful tool to improve pacing. We don't need to implant the temporary electrode to the right ventricle. We just use the wire that's in the left ventricle, and we need it for pacing. And sometimes it's not working properly, but this device can help this. So very few remarks about another disease which is almost equivalent in terms of the population involved is the mitral regurgitation. You see this on the top left and top right, and in the middle there is a very well established way of minimally invasive treatment of this disease, which is the edge-to-edge repair by clipping using the mitral clip or Pascal devices. And this improves outcomes. Those patients live longer and they spend less time in the hospital. But in some cases it cannot be done because of the leaflet calcification, because of the leaflet coaptation gap, leaflet length, and so on. So the engineers and physicians thought that it would be equally easy to implant the valve like in aortic position, and it came out that it's completely different story. There are at least 20 devices, many of them are out of the market, and it doesn't really work in the same way like aortic, because mitral annulus and mitral leaflet, mitral apparatus is much more complicated than the aortic one. So there are many investigational valves, and only one or two of them are approved for clinical usage, but they are done by transapical approach, and those not requiring any chest intervention done by venous access are the valves we implant within the clinical studies. So there are valves based on different concepts, different anchoring methods, and so on. And I don't think any of those valves is ready for clinical use at the current stage. The access is up to 39 French, so it's a huge. For most of those valves, we have only clinical experience with fewer than 50 patients, and many of them were done transapical. This is one of the examples. This is one of the valves we implanted in our site. So you see how complex it is. It requires putting a ring across the mitral valve by coming through the aortic valve in a retrograde manner, and then implanting the valve in this in this ring. So it's a very complex design, and it's very this engineering of this valve. It's I think very sophisticated. So this is the valve. It works well, but this procedure is very complicated, and it's not really very well validated. So this will be the future, and I think the engineering and pre-procedural planning with CT may solve those issues. And as you see, when we screen the patients to enroll them for this valve, 80%, so vast majority of the patients were rejected because of the size of the annulus, because of the risk of LVOT obstruction. So if you put $100 million in a device that can be used in 15% of your patients, it's still something that requires a lot of thought. So there are new designs that will allow broader inclusion criteria. I will not discuss them in the details, but this will be the future, but probably only for minority of patients. So in summary, valve heart disease is very common and leads to mortality and morbidity. And minimally invasive treatment is highly effective and safe, but progress is directly dependent on engineering by expansion of the imaging tools, materials, and the IT methods. Thank you very much.
Thank you very much. And the last one will be two young colleagues, Norbert and Tomek. Can you come to us and introduce our IT solution in the medicine?
Thank you very much. Good afternoon, everyone. My name is Tomasz, and together with Norbert, we are responsible for implementing modern solutions and improvements in IT department at American Heart of Poland. In this short presentation, we will introduce the integrated PACS systems and how it benefits our operations. Our goal is to show how these tools help us centralize data, support remote work, and make things easier for our medical staff. Our main is PACS, which stands for Picture Archiving and Communication System. PACS stores all of our images in one place, making them easy to access. We have integrated PACS with our hospital information system. This means patient records and medical images are linked, saving time and reducing mistakes. PACS is the foundation of our workflow, allowing us to connect with many advanced images, analysis systems, and more. PACS connects to several important systems that support different medical areas. The first one is IntelliSpace Portal. IntelliSpace Portal is the system that helps radiologists analyze images faster and more accurately. It uses machine learning and AI tools to automate tasks like image pre-processing and segmentation. We also use IntelliSpace Cardiovascular, which gives us cardiologists a deeper look into heart function. It works similarly, providing faster and more precise analysis. For echocardiograms, we rely on Cascardia. This system offers specific tools for these diagnostic images, making our echo analysis more efficient. In building this workflow, we always keep our patients in mind. We offer the MyView platform, which allows patients to access their medical images, reports digitally, saving them valuable time, as we see on this architecture. And we have also AI RAD, what we want to present, and Norbert will present AI RAD.
Good afternoon, everyone. Thank you, Tomasz. I am Norbert. In American Heart of Poland, I am developing artificial intelligence and implementing new systems. Today, I want to say several words about AI-RAT. AI-RAT is a companion modular software designed to support different imaging tasks, including CT, MRI, and X-ray analysis. The solutions integrates deeply with our workflow, as Tomasz said, and improves the accuracy and speed of diagnostics. It leverages advanced deep learning algorithms to analyze radiological data. Right now, we are testing one module, chest CT, because of current diagnostic needs. Technically speaking, AI-RAT is using DICOM standards, a universal format for medical imaging, and is easily integrating with PACS and any medical device. On this slide, on the schema, you can see how workflow with PACS work. The medical device is sending the encrypted data image to AI-RAT. AI-RAT is processing the images and sending to PACS. In the same time, medical device is sending images, original images to PACS, and the radiologist can compare images from AI-RAT and original from the medical device. This enables faster and more precise diagnosis. Yes, and on the next slide, we can see advantages for IT and radiology. And the first one is streamlined workflow. By automating routine image analysis, radiologists can focus on more complex cases, while IT ensures smooth and efficient data process. The second one is seamless integration. As I said before, is DICOM-based workflow, and it's easy to integrate PACS with PACS and imaging devices. The first one is enhanced data management. This is really important for all organizations because this standardized data produced by AI-RAT not only aids radiologists, but also improves our ability to analyze and utilize data within the IT department for broader insights. And the last one are centralized control and scalability. This is really important for IT, but not only for IT. With cloud-based updates and centralized management, maintaining and scaling the system is straightforward and performance can be monitored effectively. And on the end, I want to say a few words about this chest CT model, what we are testing right now. This model helps identify and measure lung nodules, analyze lung parenchyma, and assess cardiovascular structures. For IT professionals, the critical aspect is the module's efficiency in processing large volumes of data quickly without overloading the network. It's really good for us and for medical staff because they don't have to wait a lot of time for processing images. In summary, I can say AI in radiology is innovation solution because the radiologists can analyze faster, the easier stuff, easier series. And I think that will be a vital role in the future of healthcare, IT and radiology. Thank you for the attention.
Thank you very much. It was the last presentation.
Okay, thank you. Thank you so much. And actually, at the end, I would like to thank for today's sessions for all participants and for speakers and for all attendees. But at this moment, I officially close today's session. And right now, we've got 7 minutes to transfer to Hotel Zabrze. Okay, so the transfer is performed individually. So